So you do not remove the bandage until the antivenom has been given. So if the patient is envenomated, then the bandage can be removed after antivenom. So they do the testing and then give antivenom and then they release it. So you can see different guidelines, and I think it's the only most controversial, the pressure immobilization regarding all the first aid techniques that have been described. What about traditional herbal medicine? It's also described, if you see it in some of the articles. The ingestion of plant extracts and local application of the herbal medications have been really mentioned, but it lacked any robust evidence for that. And many of them even are toxic, such as the strychnine containing monkey fruit, and it can result in secondary infection. In one of the study by Madeke et al., the use of traditional medicine was not found to be to decrease any of the envenomation really risk compared to receiving no aid. In another study in Brazil, it showed that extracts of the plant jatropha, which is a common plant there, it really reduced the local effects from snake bites, but if used as an adjunct to the antivenom. And also another plant or herb was found to reduce the lethality in a mouse model in Indian cobra, the naja. This was the Euphorbia hirta. But again, these are experimental studies and there's no robust evidence for their use. As a position statement, the WHO guidelines have found that there is actually more harm with the use of traditional therapies, and their use is discouraged, and the recommended first aid is really to reassure, immobilize the patient, and move them to a place where they can receive appropriate medical care as soon as possible. So as a conclusion, the tourniquets cause limb ischemia and amputation. Electric shock is dangerous and is not recommended. Suction devices have no efficacy in experimental studies and cannot be recommended. Pharmacological treatment with a topical nitric oxide or trypsin injection delayed toxicity in experimental studies, but as of now, there is no solid evidence to recommend their use. The pressure immobilization bandage, compression bands, and rings have shown in experimental studies to delay systemic venom absorption, but it should be individualized to certain regions, species, depending how timely there is a definitive treatment, and to your local guidelines. Antivenom is the definitive treatment for venomous snake bites and should be administered as soon as possible. Splint rest and avoidance of the movement should reduce the movement of the involved extremity and should be really the practice for first aid. That's it. Thank you.
Thank you. Any question? Any comments?
No, that was a great review of it. But these, these what we call first aid. In the U.S., another company came up with a new extractor. Another one came up with a pressure bandage that now has a hole in the middle of it. And lots of them are driven by financial, by financial nonsense.
But the other thing that's important, and I've been to Australia, I don't know if this is applicable in some of the countries where most of the patient will be in hospital within an hour or two. Well, in Australia, you're talking about 9, 10, 12 hours. That might have an influence as well. Next speaker.
An Australian colleague here.
Yes, please.
Okay, thank you. I'm going to talk about the antivenom storage project in Thailand and the conflict of interest, and just give you about general idea where Thailand is here, and this is Turkey, and this in the Middle East, and we have about 69 million people in the country, and for toxicology coverage for all 69 million people, we only have about 20 toxicologists in the whole country. And we have 2% control. All of the 2% control is in the middle of the country. This is the whole country. This is Laos, Vietnam, Cambodia, Malaysia, and Myanmar around here. And we have 7 significant toxic snakes, venomous snakes. Up here, there are vipers. This is Russell viper. This is Callosulasma lodostoma. It's a pitch viper. This is a pitch viper as well. This one is found in Bangkok a lot, about 90% where I work. And this is cobra, king cobra, and crates. So from 2010 to 2018, about 6,000 cases reported to one of the poison control center, with the mortality rate about 1%. But we have about 5,000 to 6,000 snake bite cases per year.
Where poison center?
No, for the whole country per year, annual bite rate. But only 6,000 were reported to the poison, one of the poison control. We have 2 poison control, okay? Between 2010 and 2018, and that is about 1% death rate. And in Thailand, we come together and we have a society called Thai Society of Clinical Toxicology. We do the guiding and collaborating national organization for better serving poison and overdose patients. And also we oversee the medical toxicology fellowship training, and also we do guidelines, book, and also we host conferences.
How many toxicologists did you say you had?
About
20.
20. In 2000, we come together and in 2010, and then we established one project. This is based on what's going on in the country. We know that the market of antidotes is small. Often their patents have expired. Demand is unpredictable, and sometimes profit margins are very low. And pharmaceutical industry has limited incentive to develop, and it's not their interest to produce and improve the antidote and antivenom. Moreover, the antidotes are expensive, and sometimes they have a short shelf life, which discourage individual hospitals from keeping large stocks. So WHO recommends establishing a central bank of antidote as an effective and efficient way to ensuring prompt access to these drugs. In 2002, the National Health Security Office in Thailand set up a special system to improve the system to high-cost medicine. And medicine was selected and procured centrally. Okay, that is the I think the key word that I'm going to talk about. And manage all the supply chain, and was outsourced by the government pharmaceutical organization, which called GPO, to the private sector. By this method, we can save about $1 million a year.
1 million or 100 million?
I'm sorry, 100 million.
Oh,
100 million US dollar a year. And also, even we have the new innovative, the way that we can reduce cost of medical care by having the central procurement of the medicine, but we still have some challenges for the antidote and antivenom. So we want to improve the way that we have access to the antidote, and the antidote we have problem with accessing it, but for the antivenom we have another problem. The problem is that because it has a wastage a lot, because each hospital want to stock their own antivenom, and sometimes they stock too many, and then it's just go expired, and then they just discard those medicine. And sometimes we have shortage of antivenom because this hospital have too many, another hospital cannot buy enough, something like that. That is a problem.
Antivenom is produced where?
Antivenom is produced by the Thai Red Cross in Bangkok, and it's non-profitable organization, and it is WHO collaborative center for
And
snake
the
bite.
cost of it to a hospital?
One vial is about $30 US.
30 US dollars.
30 to 40 US dollar, not expensive at all. It's cheap.
That's cheap.
Yeah, and because it is FAB Prime 2, and we only give one time, 5 vial one time, at most 2 or 3 times, Yeah, it's not expensive, yes, because we produce it ourselves. And some of the antidote in this stockpile, we also ask the Thai Red Cross to produce for the country as well. So we have like antidote for cyanide for sheep, methylene blue very cheap as well, because we can produce in our country by the Thai Red Cross and the government. And the program made intensive use. Our program also use the extensive use of information and communication technology, and not only to support the procurement and supply chain, we also use the tele consultation by the process center to help healthcare provider in the remote area to manage the patient, and also to prescribe antidote and also antivenom. So this is the National Antidote Stockpile Project established in 2011 with all of these organizations: National Health Security Office, GPO, Thai Society of Clinical Toxicology, that is two poison center, Thai Red Cross. These guys, they help us to produce antidote, and this one is to produce antivenom. This is the first set of antidote in 2012. You can see that no antivenom at that time, but a later year we included antivenom. We have 7 kinds of venomous snakes, but you can see we have monovalent, which is one antivenom for one species of snake. We also have polyvalent as well. In Thailand, we have 2 groups of venomous snake. One is neurotoxic, like cobra, king cobra, crates. Another one is for hemotoxic, is viper. Okay, so we have polyvalent for viper and one polyvalent for neurotoxic. So it's really easy in Thailand. When somebody come in with paralysis, we give polyvalent for the paralysis. And if they have like after bite and they have breathing, we give the polyvalent for the hemotoxic snake.
And that one is made in the U.S.?
No. It's something wrong. It should be something else, not USA. Yeah.
So all of them are produced within
The same.
Okay.
The same institute.
Thai Red Cross?
Yeah. We have 7 types of snake, but we have low incidence rate of king cobra bite because they are in like jungle. Usually people don't get bitten really very easily. So we did not stock it. We did not keep it in this project. We asked them to use the polyvalent instead. Okay, because
why they have the monovalent like multiple? Why
because monovalent is in a long time ago. We just produced the polyvalent, and the number that the manufacturer produced the antivenom more for the monovalent and less for polyvalent.
But I don't know. And most of the time, these patients they'll come without
No, in Thailand we know.
We know which snake has been.
We have a diagram to identify which one is which snake. Yeah, and many times they bring.
And the patient they will bring the snake with them.
Yeah, many times. They snake. Okay. Yeah. And in Bangkok, we only, for the viper, in Bangkok, we only have green pitch viper, so it's easy for us to identify. And also for neurotoxic snake, you know, king cobra usually in jungle only, not in the city. If somebody has paralysis after bite, it should be cobra. We know, yeah. We have epidemiology study about that too. And this is all the antivenom. Some of these are exported to USA as well. I see some of these adults at the zoo Atlanta 8 years ago, 10 years ago. Yeah.
We have in Phoenix Zoo, we have also.
Oh yeah.
Because the exotic.
Yeah, because
Yeah,
of the exotic.
Yeah. I also had a publication about exotic snake bite in Quintox into back 2010 probably. Yeah, you can look it up. I write about it. And this drug accessibility, we use the IT technology. We use the Geographic Information System, the GIS, and we stock it based on the risk and the agency of the antidote and the antivenom. You know, for example, for the antidote for cyanide, it has to be at all of the level of the hospital because it's needed in 1 hour, something like that. But something really expensive, something not really emergency, like antitoxin for the botulism. Because it is very expensive, we only have it in Bangkok, and then we can fly it to whatever happens. This is based on the urgency, like cyanide antidote. You can see all of the provinces in Thailand. The mercaptan, fewer, and then botulinum antitoxin only in Bangkok.
Do you locally produce it? The botulinum?
No.
Very important.
Botulinum is from Germany,
Germany.
and it is heptavalent. I'm sorry, trivalent.
Right, well.
Trivalent. We only have we only procure about 10 vials a year because we don't have that much, maybe. Yeah. And this is the web online that any hospital in Thailand can access, and they can know exactly. It's in real time. You can pinpoint the antidote, antivenom in real time, and you know the stock in real time.
Yeah, we have a similar thing called antivenom index.
Yeah, I'm going to.
All poison centers have access to it, so that they know where exotic.
And you can put
Only
like.
exotic?
No, we have both. Everybody else has non-exotics, right? It's the exotics that you have to procure because you need it, and they're not available. So, based on the zoos, based on the various institutes, research institutes, like in Tucson, we have an agreement with Phoenix Zoo because we have our own exotics and our own snakes. So we have an agreement with them to keep certain number of vials of exotic snake antivenom.
Yeah, it's everywhere in the US like this. In Atlanta, the same thing. I did the exotic thing by Drew at the zoo Atlanta. They also have a whole refrigerator for antivenom from outside the country. Yeah, any kind of toxic animal they have, and if the antivenom is available, they have all of those antivenom in the fridge. Okay. I'm going to finish soon. So after we put everything, we want to know like what kind of antivenom, what is the antidote, what is the distance that we can go, number, address, hospital, and then we can know exactly where we should go for. And relevant changes after we have this project is adjusting the sub-national stocking and distribution of antivenom to match the local prevalence of snakebite cases, resulted in more efficient stock management and also reduce the cost. So how much we reduce it? You can see here it's about $2 million US dollars, and in 2012 from 2.2 million US dollar down to 1.2 million dollar in 2013 to 2016. It's about 50% cost reduction. And this is because we for example, when antivenom is like 6 months, it's going to expire, and then they relocate that antivenom to another place that has high turnover rate of the antivenom, something like that. And this is already published and also on the lesson from the field on the WHO website. You can look it up. And for the summary of the main lesson learned, the strong and sustained policy support and full funding from the national budget ensure adequate supply of essential antidote and also antivenom. And a web-based centralized procurement and distribution ensure these essential medicines were available, minimize cost, reduce waste, and save lives. Thank you.
Thank you very much. So at that time, we'll progress to the next session on the debate on pre-medications. Dr. Mohammed Al-Mohammed.
Yeah. Good afternoon. So as I totally agree with Dr. Ashraf, our community different than USA. So I remember in the emergency department once there is a family of 5 people. They came to the emergency because they found there is a snake in one of the rooms. They are seeking to be examined and to be screened because they get scared and maybe they had a venomous from this snake. But yeah, people, they are always seeking to have an intervention. You have to do something for us, otherwise you are not a good doctor, or will go and complain. Even if they have a problem after 10 years, they will say, oh, that's because they missed that snake. So I will start my talk about debate actually. So it is a debate regarding the pre-medication. So just to convince you, this is my aim actually, our main objective to convince you with what I will do is to give the pre-medication before the antivenom. To convince people they are very expert in this field is one of the difficult things, but again I will try my best to convince you. So for things like this is a controversial, we depend on many things, not only the evidence base or the study, we depend on the experience, we depend on the what we are feeling. So especially we are talking of working in emergency department, there is a lot of factors, not only studies or papers written before 10 years, before done in different ways. So I will not try to repeat the things what you mentioned, but imagine that when you have a patient, he developed an anaphylaxis after you give him antivenom. This is a very nightmare for us as an emergency physician. I remember one case, he developed angioedema, and I thought, I tell myself, if the time go back, I will give him everything to avoid this bad situation. So there is a lot of antivenom reaction, which is sometimes gets severe, to get him worse, which will be difficult. So you need to work more and more. So instead of just you give him antivenom, after that you shift it to start to intubate this patient, start him and medication is a lot of medication to save his life. There is an antivenom reaction, which is you described it just briefly. There is an IgE-mediated anaphylactic, and there is non-IgE-mediated anaphylactic explained, and there is also virogenic and the serum sickness, which is late. So this anti-serum, it is not 100% safe. It carry a lot of risk. So this is just an estimation that's it's reached to up 50%. The adverse reaction and severe systemic anaphylaxis, which is the most important things when the patient become hypotensive, cyanosis, altered level of consciousness, develop in up to 40% of these cases. There is variation in the percentage of the reaction. It's all the literature reviews depend on the production of the antivenom. Antivenom, it's not produced everywhere the similar. As one of you he mentioned it before, in the old one, now they have different technique of producing. Each country they develop it in their own way. So that carry different percentage of anaphylaxis, of complications. But depend mainly on these things. What's medication we use? Adrenaline and antihistamine and corticosteroid. So this medication we use to give it in emergency medicine. And actually this is a nice medication. So most of the time, patient coming sick, you give it, you become happy. So if I give it to this patient as a pre-medication, what's the harm of that? So let us see what's the evidence behind it, or is there any good literature supporting that? So I will be biased a little. So this one study is low-dose subcutaneous adrenaline to prevent acute adverse reaction to antivenom serum in people bitten by snake, which is a randomized placebo-controlled trial. They found that a reduction from 43% to 11% if you give low-dose subcutaneous adrenaline as a pre-medication. And there is no adverse reaction to the adrenaline were observed in this study. With limitation of these studies, but again, there show big changes in reduction from 43 to 11% from that side effects. So
where was this study and what was the type of antivenom? Do you know?
This is what I'm trying to avoid.
Okay.
I think
That's a cheating argument.
no, I mean
That's a cheating argument.
No, that's what I mentioned. Yeah, that's why it's different. So you can't generalize everywhere because the antivenom not similar in everywhere. But this is one study showed it's in the BMJ journal. This is another study in the Medical Journal of Australia. Parallel infusion of hydrocortisone, chlorpheniramine plus injection to prevent adverse reaction to antivenom for snake bites. This they found approximately 80% in the first two group to 52 in the pre-medicated group. So they compare, they make it people they give him placebo, and the other group they give him hydrocortisone and chlorpheniramine, and they found there's a reduction in the first group up to 52% of the reaction. Another studies which is apparent marked reduction in early antivenom reaction compared to historical control. This one, what he did, he collect all the historical from, he collect from 220 to 2006, and he start to give the people pre-medication and he compared with the previous one. Yeah, and he found there is a big adverse reaction from 47 to 2%. There is a lot of things regarding the study. One, the antivenom, it was different before and now it's different. Also here in this study he used previously there was a fast drip. Now in this study they started to make it a slow drip, the anti-serum. So this could be another factor, but we should consider these things as a factor also to reduce this adverse reaction. So just make it, just as an emergency physician or as toxicologist, you will give this anti-serum. It's better to anticipate than to react. So if you face one case in real life, patient he develops severe anaphylaxis, you will say, listen, I will give every patient pre-medication. I don't care for what all this is because this could reduce. Yeah, well, I know. Maybe this patient, he will develop, even you gave him, but at least you are anticipating this one by our preventing, especially if you are not sure about the purity of your antivenom, you are not sure about this, how they produce it and how there is this side reactions. So this is just, I tried my best to convince you. I'm sure you are convinced.
Thank you, Mr. Mohammed. We'll do the other part discussion.
Mohammed, he will try now, he convinced you.
No, we'll finish and then we give them 2 minutes or 3 minutes to discuss.
Okay, now I would like to talk about the mechanism of this pre-medication. For me, I will not give any pre-medications. They are using 3 medications, steroids, antihistamines, and catecholamines. So just to understand why I will not use these medications, I have to understand what is the mechanism of action of anaphylaxis and how these drugs can help us to treat adverse reactions. Then some evidence from the literature. So basically, antivenom is an effective medication to treat snake bites, but the problem is in the safety. A lot of adverse reactions has been there in the literature for a long time. Yes, it has been improved, but still, like in some studies, in some studies, adverse reactions reached up to 50%, and in some other studies, adverse reaction has been at around 10%. So there is a varieties in adverse reaction, and this is most likely secondary to the quality of the antivenom. So instead of trying to treat these adverse reaction, why not to put our efforts to improve the quality of production and to see why there's variations between the different manufacturers. So these are types of hypersensitivity reactions. Most of the reactions that we see with the secondary to antivenom are antibody mediated. We have type 1, which is IgE mediated reactions, type 2, and type 2 is non-IgE mediated, and type 3 is the serum sickness or the delayed one. So basically we have to understand the mechanism of each one of these hypersensitivity reactions and how we can treat them. So the first one is IgE mediated. Basically, IgE mediated anaphylactic reactions are early. So, and the main cause for these reactions is the presence of IgE against any component of antivenom. Antivenom, there's proteins and antigens. So if injected in someone and he's having IgE against any component of the antivenom, sorry, then they will develop this type of reaction. So this is an example of how these reactions will develop. This is the mast cell, and inside the mast cell we have a lot of inflammatory mediators, including histamines, leukotrienes, and prostaglandins, and other inflammatory mediators like TNF alpha, interleukin 4, 5, 6, and the others. So basically, once there is interaction between the IgE and the proteins, this will cause degranulation of the mast cell and will release inflammatory mediators, and this is the cause of these adverse reactions. So for example, what will happen if histamine is released? You will start to have, because we have histamine receptors distributed everywhere, so they can cause bronchoconstriction, they can cause itching and skin rash, urticaria, increase acid secretion in the stomach. Also, they can act in blood vessels, cause vasodilatation and inflammation of sinuses. So, to summarize, IgE-mediated anaphylaxis are early caused by basophil degranulation and release of histamine. So these are clinical manifestations. So the other types of hypersensitivity reactions are related to complement activation, and they will have the same clinical manifestations. Like they will have increased vascular permeability, vasodilatation, skin rash, urticaria, and pain. So the last one, which is the late reaction or the serum sickness, this usually occur within like 5 days to 2 weeks after antivenom administration, and basically the patient, they will present with skin rash, sometimes renal involvement in form of glomerulonephritis and lymphadenopathy. So these are the medication that has been used for treatment of the adverse reactions. The first one, histamines, steroids, and catecholamines. So if we go for histamines, they will act on antihistamines, they will act on H1 receptors. So basically they will prevent adverse reactions secondary to histamine. They will not prevent release of histamine. Histamine is released already. So even if you will give a pre-medication, they will not prevent release of histamine. So only they will counteract the actions of histamine. So theoretically speaking, they are not useful in treatment of these adverse reactions. So what about the literature about histamines and steroids and preventing adverse reactions? This study, what was the result of this study? Yes, they found that pre-treatment with low dose adrenaline was safe and reduced the risk of acute severe reactions to snake antivenom. But for others, adrenaline significantly reduced severe reactions to antivenom by 43 in 1 hour, 43% at 1 hour, and by 38% up to 48 hours. So steroid and antihistamine, they did not. So there's no evidence from this study that antihistamine and steroid can prevent adverse reactions. Yes, there's evidence about only adrenaline. So again, another study, in this study again, they concluded that yes, there's evidence about adrenaline, but the other antihistamine and steroids, there's no evidence that they can prevent adverse reactions. Again, this is another study done in Australia. They found that hypersensitivity reactions occurred in 11 out of 40 patients receiving any form of pre-medications, like so 28%, and 2 of the 11 given adrenaline for pre-medication, versus 20 of 86 not receiving pre-medication. So they concluded in this study hypersensitivity reactions were not common, but most were not severe, and pre-medication was not associated with any reduction in these adverse reactions. Even, for example, steroids, we know that steroids, they will need time to act. Like they cannot, yes, they have a lot of beneficial effects, but their effect will take time. They cannot like, they have effects like within a short time, like 1 hour or minutes. They need time to suppress immunity, decrease antibody production, etc. So steroids, there was no evidence about their beneficial effects to prevent these adverse reactions. Antihistamine also, it has been found no beneficial effects in preventing adverse reactions secondary to antivenom. Adrenaline only has some evidence. So in conclusion, so there's lack of evidence about the efficacy of hydrocortisone, lack of any evidence about the efficacy of antihistamine, some evidence about efficacy of adrenaline in reducing adverse reactions. But again, most of these studies, yes, they mention that some beneficial effect from adrenaline, but none of these studies has been talking about the side effects. Adrenaline is a medication, and also it has a lot of adverse effects, including cardiovascular and CNS manifestations. So none of these studies has been talking about the adverse effect of adrenaline. Even why I will give a medication without clear evidence, and also it has some adverse effects. Also, adrenaline can be used as like a treatment. Once these patients they will develop the adverse reactions, yes, it successfully can be used as a treatment, not as a prophylaxis. So we need further clinical studies needed to confirm the efficacy of these medications. In conclusion, we have to concentrate on the quality of antivenom, not on like to prevent interact with the adverse effects. If the quality has been improved, most of these adverse reaction will be improved. In some countries, like it reaches up to 50%, which is very high, and in some countries 10%. And for us in Saudi Arabia, it's less than 5% that we have an adverse reaction. So we have to concentrate on improving the quality of antivenom. Until this improvement will take place, so we have just to be prepared. If any patient is having any adverse reaction, management of acute as well as delayed reaction may occur. So just be prepared. Like, okay, use steroids, adrenaline, everything should be prepared in the health department. If the patient is having any of these adverse effects, then it can be used as a treatment. But for prophylaxis, I will not use these medications.
So can we have
Maybe he has a response. 1 minute, 1 minute.
Okay, so as he mentioned, he put all the studies that supported. The first one, they said low dose in epinephrine, it's reduced the adverse reaction. And there is a study also that I mentioned that said there is no reaction from the epinephrine when they use it. Agree with the antivenom, the quality, yes, but again, we don't know. We don't have that. You can't say 100%, and there is variety between the adverse reaction between this antivenom. So for me, working in emergency, instead of I observe the patients, keep myself busy and prepare the nurses, I will give pre-medication and I have fun.
Have you tried to do your own study for those to really randomize those with pre-medication, those without pre-medication? If you really have experience with that?
No, actually,
You just pre-medicate everyone?
Yeah, my experience only one case. When I faced it when he developed a severe anaphylaxis, this is my personal. After that, I said, I will give pre-medication, whatever they recommend, because I was in very bad situation with the patient. He developed angioedema and he has hypotensive from the medication. The family, they said, what did you give him? I gave him, this is the treatment you're seeking for.
Muhammad?
Again, like in these studies, one study, the adverse reaction was 50%. Like for this patient, I prefer not to give the antivenom. If you give antivenom, you will have 50% of your patients, they will have severe adverse reaction. I don't know what is the mortality rate from the snake inflammation by itself will not reach 50%. So it's a very high adverse reaction, most likely secondary to the quality of these antivenoms. We have to concentrate on how we can improve the quality of antivenom production. Plus, again, steroids, their effect will be delayed. You will not have immediate actions. Histamines, again, they will not prevent, antihistamines, they will not prevent release of histamine. So even if you will use them, they are not useful. only they can like counteract the mechanism of already released histamine. Adrenaline, yes, there's some.
So you agree with me? You will give adrenaline as a premium?
No, no.
So he agreed. He said.
There's evidence, but still adverse actions of adrenaline have a serious adverse actions, including cardiovascular, CNS manifestation. Adrenaline is useful as a treatment. Why I will not use it as a treatment? Like if someone is having like hypotension, why I can use it as the treatment choice, not like as a pre-medication. This is
we'll have let's say 2 divisions,
Three.
three divisions goes.
Okay.
Make it quick, please.
I think we should weigh between risk and benefit. And same thing in Thailand, we only have 3% of anaphylactoid reaction. Whatever, like anaphylactoid, anaphylaxis reaction, we only have 3%. Yes, if your country have like 80% of reaction, I would think it would be benefit from pre-medication. But for 3%, even the reduction rate like 30%, you will, reduce from 3% to 1%. But you have to think about the risk of giving the pre-medication as well.
Can I ask you a question?
Yeah.
You have an experience with anaphylaxis reaction. So
Only-
the adrenaline, in what form you give it in that scenario?
I did not give pre-medication at all.
No, no.
Yeah.
You have somebody developed anaphylaxis reaction in front of
Mhm.
you. This is a practical dilemma. So how would you give that adrenaline?
I am.
And that might be a problem for people who
I
have.
know. I'm going to
Yes.
I'm going to talk about it. We discussed about this too. So we only use we call it insulin. The insulin syringe,
That's
which
a problem.
is very small.
But that's a problem. You are giving it subcutaneously,
Yes, yes.
and you're probably not treating it
No.
because the absorption is very, very slow.
Yeah. I
And
know.
this is a dilemma, and I've had that question
But
before.
because
I don't know what's.
We only have really low rate.
Yeah, we treat, if you can give it IV, you gotta give it IV. If
that's
you
what I
can't
did.
give it
That's what I
IV,
did. It's
then
just
IM,
dilute.
but
Is that
you
what
need
did?
actually a good sized needle, and you need to have it needs to be 1.5 inches to go into
And
muscle.
then you're gonna get a
But
hematoma.
let me give
with
you
infection.
let me give you a scenario. I think what we forget, and in toxicology especially because we're acute care, we forget the psychosomatic. I would tell you, I'm sitting here, I'm very atopic, okay? I haven't been given antivenom, but I would suggest you come. I tend to scratch. I say, come rub my arm right now, and you see how it's bumped and how red it is. It's a reaction for which probably if I was in the ED, everybody would have given me they would have given me antihistamines, epinephrine, and such. And we forget these things. Lots of times patients who come in, and that, I was just looking at a study that was done by our colleague Jeff Ispitz, they're looking at anaphylactoid reaction. Anaphylactoid reaction is also, lots of it has to do with the psychosomatic response of the patient. And I would suggest the effect of the antihistamines is more psychological.
Yeah.
Okay? If you give them benzodiazepine, they probably would not become as atopic. As again, come here, rub my arm, and you'll see that, oh my God, Shirazi over here needs epinephrine. No, Shirazi's over here is atopic and just sits, even his clothing causes him to have lumps and bumps. And those are the type of things that we forget. Also psychological response. One of the main things, I've gone and talked to toxicologists who they claim that snake bite envenomations doesn't have any psychological response. Now, most of us know that, and nobody has done clinical trials, that you don't need a snake bite and then being rushed to the hospital in order to develop night terrors or psychosomatic response. I have a tox clinic and I see these type of things to it. But most toxicologists, you ask them, say, acutely, no, they don't exist. And they say it like they know it, and it's easy to come up with, again, what I say, nonsense. And not everything, you gotta realize that not everything can be reproduced by clinical trials. Just because you had 50 people in each arm, okay, it doesn't mean that everybody in that arm is gonna develop any type of anaphylactoid reaction so that you would treat or not treat. So,
I have just, till the time you have anti-snake venom which has a foreign protein, you have the risk of a reaction, right? Now, he's made a very valid point. Find out what is your proportion. even if it is 50%, you know, you are giving pre-medication to 50% people, and it is a medication. It can have potential consequences.
I've seen MIs actually.
That's very, very important.
So who is using pre-medication? Just to know.
I don't.
Who's using?
I don't. We stopped the infusion and
For pre-medication, I might give somebody a benzo just to chill them out. Because I know that person is gonna have not an allergic reaction, but they're gonna go haywire. But I've seen MIs actually from, you know, severe bee envenomation, and they gave the individual adrenaline, 89-year-old, and of course the troponin bumped.
But you have to be careful in tropical country, because if you give benzo, many patients got bitten by cobra. They have, you know, neurotoxicity, and you don't know if this is from
I would
venom
suggest-
or this is from
I would
benzo.
But we're
suggest-
talking about 1 milligram or 2
We're
milligrams.
talking about looking at your patient and
I
treating.
know.
Yeah.
The fact that with most of the medicine, you know, the reason it's also art is that you know which patient of yours is going to freak out, okay? And I had a guy that jumped out of a plane, his parachute didn't open, a military guy, landed, broke both legs, tib, fib, and his femur. And he's sitting there, asking him, do you need any pain medication? No, sir. Okay? And then I have a guy that his finger, you know, has a nail, is, oh my God, get the surgeon in here.
It's very individualistic.
Yeah.
That's what
That's totally
at
true,
the end of
yeah.
the day.
So welcome Bruno, and now we diverge to Europe.
We'll talk about a French experience with Botrops lanceolatus. So you will tell me why France has a position in the snake envenomation symposium. Because of course in Europe there is really not an issue with snake bites. In France we have only vipers, and we have two kinds of venomous vipers, Viper virus and Viper aspis, and we have a very efficient antidote, which is FIB2, and we just give one vial and generally everything is okay. But maybe you don't know that France has also some islands in South America. And we have Guyana, with probably the second largest Amazonian area in the world after Brazil. And we have also a small island called Martinique, you see on the map. And so this is a French overseas department in West Indies. And what is very interesting in Martinique is that we have a snake there called Botrops lanceolatus, which is a specificity of this island. It is a member of the Crotalidae family. It is considered to be the only snake involved in this Caribbean island, and it is venomous. And you find this snake only in this island. So this is the only venomous snake in this island, and you don't find it anywhere else. And it is estimated to have about 20 to 30 reported bites per year. Also probably it is underestimated. So the toxicity is related to the Botrops family. So you have what we call botropic syndrome, with the rapid onset of lesions at the bite site with hemorrhage, pain, edema, leading to dermomyonecrosis and local infections with possible severe sequela, and also systemic symptoms with circulation impairments and hemorrhage syndrome and acute renal failure, as you know. That is the botropic syndrome. Botropic syndrome, of course, I will not focus on that, I will go rapidly, is related to various enzymes contained in the venom that may act at different levels, inducing vasoconstriction, activating platelets, activating plasma coagulation, and even fibrinolysis. Botrops lanceolatus is quite different. It belongs to the botropic family, but it has a quite different outcome. The major enzymes in its venom is hemorrhagic snake venom zinc-dependent metalloproteinase called hemorrhagins, and these, in this species, is responsible for vascular damage with endothelium injuries. So it inhibits the coagulation, it activates platelets, and it results mainly in prothrombic activity. So with Botrops lanceolatus, you will have the local signs, symptoms like with all Botrops, but from a systemic aspect, you will have thrombotic complications in 30% of the patients with brain, cardiac, and pulmonary thrombosis. So no hemorrhage, only thrombosis. And this will lead to organ failure, mainly neurorespiratory failure, death in about 15% of the patients if not treated, and sequela in 20%. So the difference, it belongs to the Botrop family, but it doesn't give hemorrhage, but just thrombosis, extensive thrombosis due to endothelium activation. Hopefully, we have antivenom, which is Botrofab antivenom, so which is just a specific antivenom dedicated to this snake, produced by Pasteur Mérieux. It is obtained from hyperimmunized horses. It contains FAB2 fragments mainly. As explained with other antivenom, its regimen is adapted to the inflammation severity. It was synthesized and first administered in 1993, and it is effective to prevent the consequences of severe bites if rapidly infused, and of course its effectiveness is function of the rapidity you administer it. And till 2000, we have a certain experience with this antivenom. It was published, this experience was published in Toxicon in 2006. About 110 patients received this antivenom therapy within 6 hours and no thrombotic complication occurred. So it is quite efficient. Unfortunately, since 2000, complications reappear. So this is, I think, interesting for MENA region because we will see the reasons. And we performed a study on the 10 years between 2000 and 2010. So this study included about 100 patients envenomated with Botrops lanceolatus and treated with Botrofab. So you see that, of course, we have the local usual complications, but strokes reappear. Where it was 0, some stroke reappear, and even one death occur. 9 patients developed ischemic strokes, including 6 who received the Botrofab within the 6 first hours. So suggesting some resistance to this Botrofab that appeared since 2000. Of course, not all neurological lesions were clinically symptomatic, and you see that MRI performed in these patients showed various thromboses in various areas, but what was characteristic that almost all the patients have infarcts in the territory of the posterior inferior cerebellar artery. So, like, this was very specific with this bite, this envenomation. You see here that they have a bilateral infarction in their cerebellar artery, and the branch, the posterior and inferior branch called PICA. So all these patients had a PICA infarction, which is not usually in common patients. There were also other CNS injuries. Here you see injuries in the caudate and bioccipital infarcts. Here bilateral junctional infarcts. And in all these lesions you have diffuse thrombotic microangiopathy. This is the case of the patients who died with infarct in the cerebral cortex and obstruction of the small arteries. We, of course, studied the clinical parameters of these patients, and we saw that all these patients presented biological signs of coagulopathy and elevated troponin in comparison to those who did not experience these complications, and these appear to be key indicators to suspect brain thrombosis. And thrombocytopenia was, in the multivariate analysis, suggestive of this neurological accident with the PICA complication. So, to summarize a little bit, so during the first 10 years of the 21st century, we observed an elevation in the incidence of stroke despite the treatment of the patient with an efficient antivenom with an incidence of about 9%, a mechanism of ischemia induced by coagulopathy, with a documented case of endothelial injury with microangiopathy, and in almost all the patients, junctional thrombosis in the brain, reaching mainly the PICA artery. And this is, of course, very specific to our botrops. So we questioned about decrease of efficiency of our antivenom, which is specific and proved to be efficient 10 years before. So maybe the same case that we observed. So we hypothesized different possibilities. The one which is probably the most exact is modification of the venom composition, because the first antivenom was produced based on 25 snakes caught in Martinique, and they were adult snakes. And probably the new, younger snakes developed new epitopes, and those are not covered by the botrofab antivenom. So it was requested to produce a new antivenom, and about 130 snakes were caught in Martinique, mainly now young snakes, and their venom was collected, and a new botrofab 2 was produced by the Pasteur Mérieux, because this is a public health issue in France, in Martinique. So a new antivenom was produced in 2011, and since that date we made an observational prospective study, and this is the preliminary results of 7 years of observations. We treated 160 patients with grade 3 and 4 envenomation with this new antivenom. So the delay was relatively short because the island is small, and of course we observed local complications in the majority of the patients: edema, pain, bleeding, but lower rate of troponin elevation and no thrombotic complications of fatality in none of these patients. So we were able to produce a new antivenom based on changing in the epitopes, and it seems now to be efficient again. So
Bruno,
we appear to be optimistic.
Younger snakes
So-
have the epitope?
Sorry?
Younger snakes have the
Yes,
epitope?
yes. This is the hypothesis, but it is still not proved.
Okay.
So we have a collaboration with the team of Guterres. I don't know if you know him. He's a scientist that make experimental studies on snakes, and he's currently studying these antigens from different species, and especially that to answer
So
this
originally they were all adult snakes? That
Yes,
the
originally.
pasteurs
The first antivenom was produced from adult snakes.
Okay.
Then there was a failure 10 years later, and we produced a new antivenom, and now it's efficient. So we can be optimistic for the future. Unfortunately, no, because last year the pharmaceutical company decided to stop manufacturing this new antivenom. So now we have also some problems, and now we are testing different Brazilian, Panamanian, and South American antidotes that are directed against Botrophab families to see if they act on this specific Botrophab lanceolatus and to choose the most efficient one, because probably in 2 years, 2 or 3 years, when the storages will be finished, there will be no effective antidote to this Botrophab.
Who produces it? What pharmaceutical?
Pasteur Mérieux,
Okay.
which is a French
Is it
company.
Is it a private?
Yes, it's a private. Yes.
Okay. Is Institut Pasteur used to be a public?
It is. Institut Pasteur is private too.
Not private.
Yes, yes. And Pasteur Mérieux is probably connected to Institut Pasteur, but it's not Institut Pasteur. So I thought that this experience could be interesting for you, because here we have some certainties about the epidemiology, because we know exactly the snake, because if you have an envenomation in Martinique, you are sure that this is only this snake, because there is no other venomous snake, and this snake only exists in Martinique, nowhere else. And it is different from all other Botrops snake family because of its mechanism. Botrop venom usually activate coagulation and results in hemorrhage, while here it mainly destroys the endothelium and results in thrombosis.
Now we see the same thing in terms of juvenile rattlesnakes are much more coagulopathic and without getting any signs or symptoms of local toxicity. So, but in our case, using higher amount of antivenom actually reverses that. And it was interesting, and we presented this. We had 5 patients that we found actually hypercoagulable state. We found DVTs in them, which we had never seen before. So it's interesting that you have this problem, but this probably exists in other snakes, but not as prominent, because the epitopes are not.
What is here very curious is always the same localization of thrombosis in the patient that were treated, so that maybe the antivenom is not totally inefficient, but it allows to control the coagulation, but not in this very small area of the cerebellum.
Because that's
where
a
it is
different
not controlled.
question.
And how many vials do you give?
So the number of vials is adapted to the severity of the clinical features, and all these patients who develop this have the maximum recommended dosage.
Which
So,
was?
but I don't remember, but I can send you the exact dosage. But it's the maximum one, but we don't test higher dosage. But normally it's adapted to, as it was shown, to the LD50 in mice, extended to humans, the same adaptation, with cases where the venom concentration was measured. Also, of course, in all these cases, no venom was measured, but it is adapted, and especially we have 10-year period of more than 100 cases treated with this antivenom with complete efficiency. So there was something new.
So about the juvenile snake with the more systemic effect, there's a study already published in Clintox as well. It's from Brazil. And I was the reviewer for this study, and they capture the juvenile compared with the adult, and they compare the systemic effect and local reaction. It's true. There's evidence already published.
Thank you very much.
We know it's true. I see it all the time.
Yeah, but we need to prove it.
Thank you. So I know it's not time, but if you spare us a few minutes, just a difficult case. Richard, sorry, can
We'll
just,
start.
yeah,
Can we
just,
just
We'll talk after.
in lunch.
We have
Let's
our,
talk- yeah,
we have our
Because
own
we have
set
just,
to be
we are just running late, so it's,
Severe reaction.
I thought just to share this, I discussed this earlier with Dr. Ashish Palla, and maybe I get, you know, some feedbacks from you guys. So this is a case, is a 16-year-old boy who I received the call through phone consultation on Saturday around mid of the day. And basically they think that this is a case of snake envenomation who has been receiving antivenom, but there is no improvement. And in the initial presentation, I mean, you can see that that's his foot. Usually we see, like in most of the cases that we see like quite good marks of the fangs. And you see significant swelling in most of the cases. But in this case, it looks like only bruises. There is no fangs, only like a bruise, and there was no swelling. And so the patient presented to that hospital 2 days prior to the call. The patient having significant severe coagulopathy. His INR was more than 10, his BT was more than 120, and his fibrinogen was undetectable. The rest of his examination was unremarkable, and the rest of his lab investigations, including CBC, liver function test, and renal function test, was normal. Okay, and he is not known to have any medical problem previously. So, according to the protocol that we are using, and it's not really clear, but we have this protocol from the Ministry of Health, and it's been published by infectious disease team in the country. So, and then they categorize the envenomation into no envenomation, mild to moderate, and severe envenomation based on the local manifestation as well as the lab investigation. So if you have a patient who is having severe coagulopathy, defined as a BT more than 50 seconds, INR more than 3, or platelets less than 50, or fibrinogen in less than 0.75 gram per deciliter, then that's considered as severe envenomation. And in that case, patient should get the maximum dose of the snake antivenom. The snake antivenom that we are using is the Saudi polyvalent, because we don't produce our own. And the maximum dose is 10 vials, which is 100 milligram. So 10 ml in each vial.
How much
So
does it
by the
cost
time, yeah.
The cost to the patient and the cost to you?
Yes.
A while?
No cost of, there is no cost to the
It
patient.
is like
There's no cost for the
non-profit.
patient?
It's distributed for free for all the hospitals in the kingdom and in the GCC countries. Like, I think it's free, yes? You are getting it or
No, we are getting it, but with the minimum fees, so it's not.
it's
And
not
the
like,
patient,
not cost.
patient is free
Because
of
I've been to
charge.
the antivenom institute
Yeah.
in the Haras. I've been there.
Mm.
So,
So eventually, by the time they called me, he was already 48 hours, and so he received around 70 vials, because according to the protocol, they should repeat the coagulation profile every 6 hours. If it is the same, then they repeat the same dose that they started with. So, and then they called, and the reason they called basically because on Saturday, so he presented on Thursday in the evening time, around 9 p.m. And then on Saturday, patient started to develop sublingual hematoma, but there is no active bleeding, and so they were worried. They already gave him FFP and cryoprecipitates, and his repeated coagulation was almost the same. So we said, and that's when we thought this could be refractory coagulopathy. And so I don't know what is your thoughts about refractory coagulopathy, because this was my first case of that scenario. So I looked into the literature. I didn't find much, except some is from the Indian literature, where they say they, instead of giving boluses of the antivenom, they give infusion. So we decided to give him infusion over 6 hours. So the same dose that he received, 100 ml of the antivenom, we give it over 6 hours, and we continue giving the FFP and the cryoprecipitate. The repeated coagulation after 6 hours and after stopping the infusion was getting better. So we decided to continue with the same scenario. Unfortunately, the repeated coagulation after another 6 hours was still again severely deranged, with an INR more than 10 and BT more than 120 with undetectable fibrinogen, though he showed a little bit of improvement in his parameters the 6 hours before that. So we, at that point, we decided to shift the patient to the, I will not go with this, but we decided to shift the patient to the tertiary care hospital where I work, and then I saw the patient in the ICU. The patient was fully awake and conscious, but he had a significant swelling in the low part here on the chin and in his face. And there is a hematoma underneath the tongue, but there is no active bleeding when he arrived to the hospital. And so we did the coagulation again, we repeated the coagulation, and then at that time I contacted Dr. Ashish Pawar, and he said, you might cause more harm by giving the antivenom. Let's stop the antivenom and treat the coagulopathy with the blood products and see. So we continued giving him the blood products, but his condition started to deteriorate. The swelling was getting worse, and he started to have bleeding from the gums. In fact, he was like, I think he was swallowing his blood into the lungs, and he was.
Before you go forward, why did you not continue with antivenom and blood products?
Okay,
Because
so
that's what we usually
that's what
recommend.
we usually
you know.
do. Yes. So
If you have a severe coagulopathy,
yes.
and again, the only time, when Ashish wasn't here, the only time I saw was the internist was giving blood product without antivenom, and the patient was getting worse.
Yeah, so we are talking about so that was the envenomation happened on Thursday, and we are talking about already Tuesday by the time. So it's almost like 5 days from the time of the exposure. So that's when, according to their experience, basically there is no harm after, there is no effect of the antivenom after 48 hours from the exposure.
Why I say that?
Yeah.
I showed you the data, 900 ml ASV down to 150 to 200. When you give anti-snake venom, you will only take out what is circulating in the blood.
Yeah.
Once you've given your maximum dose, whatever you continue giving is not going to take anything out of the tissue if it is already bound. If it has caused harm,
If it's already bound, but that's making an assumption
No,
that
see-
there's not equilibrium between the, and it's not coming out and going
And also
back
the
in.
site of action of the venom is in blood, not in tissue in this case.
So carry on, doctor, and then we'll have a discussion.
Yeah, so let's see what happens.
Yes, see what
Okay.
So
happens.
you stop the antivenom, you're
So
giving
I
blood
stopped
product,
antivenom, I did
Ashish
that.
is involved.
Is he intubated now?
No, so yes.
Yes, why didn't you consider that? I saw he was like a very huge zone here, where there was the.
No, that's the heel.
that's
That's
the
the
heel.
heel.
That's the
Ah,
heel.
okay.
That's
But
what the
didn't you not consider to operate this area? And
to
No,
get the
because
blood.
the-
No, when I'm in
to
need.
get
So
the
that
venom.
picture.
So
If
the
a depot.
idea is, if there is a venom
Depot,
depot,
that's what he's
that
talking about.
you can. The fact is, I'm not a believer in venom depot, but we last 3 weeks. Our venom
Yes.
lasts 3 weeks.
And there is,
We know
there is
because of
big
the
evidence,
coagulopathy.
there is big data. You can still give antivenoms even up to 7 days, 10 days.
But with the bleeding, how they're gonna
So-
do a myotomy or
And-
So
something?
no, but it's not. He basically.
Decision.
That picture,
Yes, of course, there's a risk.
he did not develop any significant swelling, by the way. It was only ecchymosis at the same day. By the second day, the ecchymosis almost disappeared.
And did
It's
we
not
do any
like it is.
studies on this
Did he
individual?
really have a snake bite?
Or did he have other?
So,
Let's
Was it
have finished-
something
let's
else?
have finished the-
so at this point, we started to question whether he actually had a snake envenomation
Yes.
or not. So we go back to the history. In fact, we involved the environmental health, and they went to the area and did screen. They did not find anything unusual. He was playing in a coastal. He lives in a coastal area near to the beach, and then he. That's what they say. Right? So they basically he was playing bare feet. And then he went back home. On the way back home, it was already dark. He felt that he stepped on something soft, and then he felt the pain. And then he heard the sound of the sound with something like, but he did not see anything. So we were not sure whether this was snake envenomation or not. But because we
Look
were
like a
not
duck.
sure whether the,
Sounds like a
the
duck.
antivenom was helping the patient or not, we decided to stop the antivenom, continue with the FFP and cryoprecipitate, and do CT chest and head, because he was becoming a little bit drowsy and he was complaining of chest pain. And the CT did not show any intracranial hemorrhage or bleeding. He had a significant myositis over this area only, not any other part. His foot was completely fine, and he had an evidence of pulmonary hemorrhage bilaterally. Maybe he swallowed the blood because of the active. So we decided electively to do tracheostomy for him to reserve his airway just in case. Then we involved the hematologist at that point, and then the hematologist said we have to do exchange transfusion, and that's another thing that came up in the management. In such a patient with refractory coagulopathy, should we consider exchange transfusion in an early stage rather than waiting for him until that stage? He received 2 sessions of exchange transfusion. He received multiple FFPs and cryoprecipitate, and eventually in the subsequent 48 hours, his coagulation profile improved. He became better, and then we discharged him home without any sequelae.
Did you send any sample of the blood for venom detection anywhere in the world?
Anywhere in the world, I reserved a
would be
sample, but
marvelous.
I don't have anywhere in the world. I do
See,
not.
there are only 2 possibilities when you have a refractory coagulopathy. One, you are dealing with, and your ASV is not working. One, you are dealing with a venom or a snake,
Yeah.
which you're not covering with your ASV.
Yeah, that's most likely.
So what's the point giving liters of ASV to a patient when you're not covering it? I don't know.
So,
I was very kind
Exactly.
of.
So now it's when, according to the snakes that we have, there are certain type of species that there was a question, there was a paper published in 2004 by a hepatologist, and he basically questioned the efficacy of this, the Saudi polyvalent antivenom against one kind of species, which is Echis omanensis, and it can cause delayed coagulopathy and maybe refractory coagulopathy.
Do you have a sea snake?
We have sea snakes. We thought about the sea snakes, but the sea snakes.
Reaction, no microbinuria.
So I looked into even the anatomy of the sea snakes. The type of the teeth appearance is totally different, and you have to have a local side because they have to have a long contact with the patient before they do the envenomation part. So which was not there in this patient.
And the CK would be.
And they don't. And
in
he
India,
was not. He was not on the shore, by the way. He
Yeah.
was in between the
inside.
houses. So
We have hump-nosed pit vipers, which are not covered by ASV. And we reported cases, we had multiple cases. One of them we reported was a severe intraperitoneal hematoma. And he stopped bleeding because there was a compression effect. It couldn't grow anymore.
yeah.
So there was a compression effect and it stopped bleeding on its own.
He survived.
We didn't touch that hematoma, he survived.
Do you have a picture?
And there was then a spontaneous resolution.
Let's see the
But
picture.
we didn't give any more anti-snake venom to them.
And no other studies was done on this kid to find out whether he had any type of a pre-existing condition?
Yes,
company?
yes.
You mean the
That was the second
Protein C,
disorders?
protein
Yes.
S
Yeah.
deficiency,
They
factor
did.
5Y, then.
Yeah.
They did, all were negative. And he'd been followed up by the hematologist, all his
So
labs.
which
came
test did
negative.
they do? When you say all of them?
I have to double check, but it's the
GCB,
complements.
GCB, usually the routine in the region.
Yeah.
We did the GCBD,
C3 and C and
Yeah, the
and
factors,
S,
the ladens.
protein S.
Factor 5
the
laden
five labels, and there's
routine
third one
CNS.
they do.
Yeah.
There's third one. That's the routine hemolysis.
And they check for hemophilia.
And hemophilia, yes, that's the.
That's
They-
standard of
They
care.
check for factor
Yeah,
VIII
standard of care.
deficiency. also.
No, that G6PD.
We have had it so that the patient appears to have a wart, and then we check him, and they had one of the hemophilia.
So the question I think for
And we had to give them factors.
so the question now for
No, because just just you talked about two hypotheses. I understood the first one, that the species is not covered. Okay. What is the second?
One is the species is not covered. Second is that if you have a circulating venom which you are not taking out, when you were saying, then the exchange transfusion. But you can't offer it upfront if you don't know what this person is having. So, see, your 99% or 99.9% of your snake bites would be the usual snake bites, which would respond to whatever anti-snake venom you give. So you can't offer it upfront. So if it is not working, then you but adult exchange transfusion is a dangerous thing. It's not so simple.
So it's clear from this case, as far as I understood it, correct me if I'm wrong, that you still have a venom active in the body because you're pouring the factors and it's not correcting.
But anti-snake venom is not acting because it's not.
So that's the second part. No, the second. So the first part.
Well, so the first part. It might be that your antivenom actually is not working at all.
It's not working at all. So that's why I said stop it.
So what I'm trying to say is, you have a venom you're not neutralizing. It's still in there because the evidence that you're giving a lot of factors and it's not correcting.
Yes.
So the question for us here is, where do you go from there? Do you set it out? Clearly, you could not set it out with this patient.
Yeah, I mean, if you look at the timing, when do you decide that your antivenom is not working?
See, we stopped giving. We stopped giving in 24 hours time whatever maximum antivenom we have given.
I agree.
And after that,
I agree.
No more. If it is not working, then it won't work. So there's no point continue giving antibiotics. You're not
the
doing
maximum
anything.
for you? You have decided maximum dose.
300 ml.
Based, yeah. But the fact of the matter is, for us, there is no maximum. I have given to the gentleman that was bleeding like, and he was the son of a hematologist. I gave him, I think it was the highest number of Crofab ever given in the U.S., which was close to 68 vials that he received. But we were able to control it.
But when you see an improvement,
and he got improvement.
So you given the first
The question
See,
is
you
is
were
it
also
spontaneous?
giving blood products. So he may have responded to the blood products, not ASV.
No. This guy came in, we got him under control, went to the medicine service after ICU and us let him go. He reoccurred, which is a common thing. The guy didn't know what to do, gave him blood products, got worse and worse. He dropped his hemoglobin to the level of 4. Then we got him back, gave him again antivenom, okay? And we loaded him, till he stopped bleeding, and then we gave him blood. And he got better.
This patient did not
so
respond
why
at
did you-
all to the antivenom.
Yeah, but that's the difference. You believe that your antivenom is going to work.
Okay.
Yeah.
But she did not believe the antivenom
The
is going to work.
antivenom is
I
going to
thought
work.
initially it will work.
Maybe it's a different species not covered.
Yeah,
That's what we
Well,
said.
that's
That's what I
That's
said.
a possibility.
So you had a belief with what you're dealing with.
So
if
the other
there's
thing is,
uncertainty-
you gotta sort of have an idea about your epitopes, right?
Yeah.
And I would tell you that majority of our snakes, now let's say it was, even if you get somebody that comes in with neurologic and we say, hey, this is not one of our rattlesnakes, right? And what I have seen, at least in my practice, that you give them enough antivenom, you cover many of those epitopes. And they do so. Crofab is not built for cobras. Have I seen a good effect? Yes. And that's why now there's a move about what they call an international antivenom or uniform antivenom.
Yeah.
Because lots of these epitopes reoccur. And, you know, who was it that put Brian Fry's study? Brian Fry studied, the good part of his study, not his human touch, but the good part of study is that he has shown that venom and reoccurrence of venom in various species has to do with the strategy that's common. So those epitopes that work in terms of a biological warfare against another species tend to reoccur. Scorpions utilize it, spiders utilize it, snakes utilize it, you know, marine, they utilize it. So sometimes you have to give massive amounts. And it does work. I know what Ashish says, but our experience is totally opposite of that.
I'd not agree with that, I'm sorry.
It's
But
okay.
because, you know, if it is not working, either prove that there is venom in the blood, right? If you can't, then it becomes very difficult. Then the only way which I think is, if you don't have an antidote for a poison, you do an exchange. We do that for malaria. We did it, we've done it for severe complicated malaria, very high parasitemia. The patient is going down, you just take out the blood and give him
Fresh blood.
fresh blood. You don't only take out the parasite, you also take out the cytokines and the inflammatory mediators, which are causing majority of the damage.
But I wonder in her case, maybe if they started early on the bonus and then in the maintenance of fusion, he would have not deteriorated, because when they started again the infusion, he improved for a short time.
So
So
that's
this means that, I don't know.
But how?
So I would tell you
Apparently
what-
not much.
It was-
Because I'm the only one in the US that usually uses an infusion. As a matter of fact, we're presenting at Venom, we had over 45 cases of continuous infusion, and we show effect, but it has a significant effect. And what I use it, and I'll be honest with you, is there are many times that even toxicologists want to bolus. They say, no, let's give an infusion over. And what it does is it also mitigates the venom effects of the toxicologist's extra activity.
So we don't, as you know, in general, the antivenom that we are dealing with, we don't give it as bolus. We give it an infusion over 1 hour.
Yeah,
So that's
we always
usually-
give
Right.
it an infusion
That's-
over 1
But
hour.
we just
Well,
extended
that's what
the
we call a
infusion.
bolus.
So, but we just extended the
Right.
infusion. But the problem is that when we recommended the infusion, the treating physician in the other facility, they added the blood products during that period.
Oh.
And then we tested the coagulation. So we were not sure it's because of the infusion or it's because of the
Do they
blood
give any
products.
antibiotics too?
They give him antibiotics, yes.
They give them
They give him
everything.
antibiotics. Yeah.
Thank you very, very much.
That's very good.
Can we have, if you don't mind, can we have a picture, all of us? Acil tıp uzmanlarına ve sağlık çalışanlarına yöneltilen şiddet hastalara, hasta yakınlarına, topluma ve tüm insanlığa yöneltilen şiddettir.
Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.